Hello everyone and welcome back to my channel. Today we're going to talk about the Neuro Anatomy of Pain. Why is it important to understand pain? Because as clinicians, we don't want our patient to be in pain. Although pain can be also considered as a protective mechanism, but at the long term, it's going to be defective, especially for anesthesia. You want to reduce the amount of pain on your patient. And in order to understand that, you need to know the different pathways of the pain. So my purpose here today is to condense the different neuro and anatomy of the pain pathway and make it easier to understand. So before we start, the pain has three major pathways. So we have the ascending pathway. The ascending pathway is gonna come from when we start having the pain until that stimulus is transported into our nervous system. Now, when we get to the nervous system, we're gonna have the interpretation of that pain. Interpretation on that pain. That interpretation is going to keep us aware that, oh, we're actually having pain, or it's hot, or this pain is sharp, and this pain is dull. It gives us the meaning to describe our pain. And we're going to have the descending pathway. The descending pathway can be confusing because we always been taught that pain follows the ascending fibers, and the descending fibers, which are efferent fibers, are considered motor fibers. But pain also have descending fibers. The purpose of the descending fiber is to modulate the pain, to help us feel less pain. So even our body system don't want us to be in pain. Now that we know the pathways of the pain, we're also going to describe the fibers that conduct the pains. So pain is conducted by different fibers. So pain and temperature is conducted by two main fibers, the C fibers and the A delta fibers. Now, the A delta fibers are going to be myelinated. So if they are myelinated, that means that their transport of pain is going to be fast. So they're going to conduct like sharp pain. Sharp pain. Now, the C fibers, they are not myelinated, unmyelinated. And they're going to conduct C for continuous pain. Like when we have dull sensation of pain. So these are the main fiber for the pain and the temperature. Now we have other fibers like for the touch and proprioception. I'm going to mention these fibers in here, not because they are pain fibers, but they are also modulator. They're going to help us as well feel less pain. And we're going to see how they comes into play in this whole pain neuroanatomy. So the touch and proprioception fibers are going to be conducted by A beta fibers. And these fibers are also myelinated. And like we saw, they are not conducting pain. They do touch and proprioception. Proprioception is when you know if your finger is up, down, left, or right. And the touch, when somebody touch you, these fibers are going to make you aware, oh, somebody touched my hair. So these are the pain fibers. These fibers are going to transport the pain through different pathways. So for the pain and temperature, they're going to transport the pain through the anterior spinal, anterior lateral, spinal thalamic tract. So anterior lateral spinal thalamic tract conduct the fibers of pain and temperature. But mainly, these two fibers are going to be focusing on the lateral part of the anterior lateral spinal thalamic tract. Because anterior lateral spinal tract contains a group of fiber, but this pain and temperature fiber, they're going to run on the lateral side. And if you read into the word spinal thalamic tract, from the spinal cord until the higher brain center, so these are afferent brain fibers. So they conduct the pain from the spinal cord until the higher brain center. And our A beta fiber, which is touch and proprioception, they're going to take another pathway called the dorsal lemniscal pathway through the fascicularis grainiform and cuneiform. So this dorsal lemniscal pathway conduct touch and proprioception. But why are we talking about this different pathway? Because they act differently and their trajectory is also different. So on our pain and temperature on the lateral spinal thalamic tract, these fibers are going to cross over at one point, and these fibers are going to cross over on another point. And because our body system into the central nervous system is built to the fact that it gives you the sensation on the opposite side. So this is why those fibers crossed. Now, if I do, let's say we have the upper brains here, somatosensory cortex up here, mainly the parietal lobe. That's where all our sensation is going to be. And if we go down here, we have the thalamus and the hypothalamus. And if we go down there, we have the midbrain. And then, so down the midbrain, we have the pons. And then we have the medulla. And then we have the spinal cord. This is just a gross example of the central nervous system. Now, the pain and temperature fiber are going to cross right here on the spinal cord. So once they receive the stimulus from the nerves, this nerve passing the spinal cord, they're going to have their decusation here. So they're going to go on the opposite side. But the A beta fiber for the touch and proprioception, they're going to have their decusation inside the medulla. So these two fibers don't cross over at the same point, which is very important. And I'm going to upload some video to talk more about the touch and proprioception pathway. But for the purpose of our video, we're going to maintain on the pain and temperature pathway, which is carried by the delta A fibers, C fibers by the lateral spinal thalamic tract. Now let's see how all this process work together now that we have the basic. So when we have a muscle, let's say we have a muscle here, our skeletal muscle, and we have a pain sensation here. Now this pain is going to be communicated to the nerve as an action potential. This is the first phase of pain transmission, which is called the transduction. Transduction. So the transduction is actually when the physical stimuli is converted into an action potential, into an electric current. Now, from this muscle, we're gonna have our fibers of pain, the A, delta, and the C fibers. Let's draw our spinal cord. Just a picture here. And so let's say we have our spinal cord here, just for picture purposes. So we have the dorsal horn here, and here we have the ventral horn. So now remember, the ventral horn is for the motor fiber, the afferent fiber. So we are not going to talk about this because we are not talking about motor anything. We are talking about pain. So these A, delta, and C fiber are going to transmit the pain into the dorsal horn of the spinal cord. So here into the dorsal horn of the spinal cord, they're gonna send some fiber up and down. So they're gonna divide and send some fiber up or send some fibers down. And this fiber that goes up and down are called the tract of Lysor. I don't know if I'm saying it right. Tract of Lysor. And why is this tract important? And it's very important because when we have a spinal cord resection, let's say somebody fell from a 3 stairs and have a spinal cord at a level. Now, below that level, sometimes we don't feel sensation. Sometimes we feel half of sensation. It's because of this tract of Lysor. So these tracts don't follow the normal pathway of the pain. The bypasses that pathway. So when we have a spinal cord resection, the normal pathway is no longer functional. This part is here to help us feel the pain at that point. So it's very important that we know this, especially for a spinal cord resect patient. So let's go back to our A, delta, and C fiber. So when the A, delta, and C fiber comes here, in this area, we have what we call, I'm going to put that in red because it's also very important, a zone called lamina 2, which contains the substance gelatinosa. So on the lamina 2 with the substance gelatinosa, this is our main modulator center. Is our modulator center of pain, because this zone is going to determine if the intensity of the pain, is it going to make the pain higher, is it going to make the pain less inhibited or very inhibited. So from here, that is going to dictate the neurotransmitter that gets that pain. Is it going to be an excitatory neurotransmitter like glutamate? Is it going to be an inhibitory neurotransmitter like GABA? So here is the gate control. This is where the gate control pain comes from, because it is considered as a gate. The pain comes through, is it going to be activated or inhibited? So this zone is very important. So when those fibers, these pain fibers carry the pain into this zone, the modulation happens, and then we have another neuron here, our second order neuron. The second neuron order is going to cross right here into the spinal cord. Remember, we talk about the crossing of the fiber. So these fibers are going to cross right here to ascend into the thalamus. Now, remember, the thalamus is the sensory headquarters, all the sensation except for the smell. So all the sensation from the pain and temperature as well are going to pass through the thalamus. When it reaches the thalamus, another neuron is going to transport it into the highest primary somatosensory cortex, which is also the parietal lobe. So this is going to be our third neuron. And here, the information is going to go through the perception to give us the perception of sharp pain, the perception of dull pain, the perception of aching. This is where it's going to happen. So transduction is where the noxious stimuli is transducted into an action potential. Now, the second phase of this pain transfer is going to be called the transmission. The transmission is when we move from the first order neuron, which are these fiber first. They're going to come transmit into the gate. The gate is the substantia gelatinosa. The gate is going to tell if it's going to be perceived as a pain or not. We're going to have a second neuron here, which is our second order neuron. This second order neuron is going to decussate the fiber right here in the spinal cord and lead this fiber to the thalamus. Thalamus is our sensory headquarters. Thalamus is going to relay the fibers into the third neuron, third order neuron. This third order neuron is going to bring it to the higher center, the cortex, the parietal cortex, where all our sensory are developed, and we're going to feel the sensation of perception. We're going to perceive the pain. And now different medication are going to act at different points. There are some medication that are going to be modulators. There are some medication that are going to alter the perception. There are some modulation that are going to block the transduction. There are some medication that are going to block the transmission. So this is why it's important to know all these phases: transduction, transmission, modulation, and perception. Now, right here, we saw that the fibers of lamina gelatinosa, lamina 2 contains substantia gelatinosa, which is the modulator, and this is where our second order neuron is, and it's going to be defining if the pain is going to be perceived as a high level of acuity pain, or it's going to be perceived as a less level pain, or it's going to be inhibitor. It does that through some neurotransmitter. So we have the neurotransmitter that are excitatory, which actually conduct the pain sensation. And our main neuron here, our main neurotransmitter is going to be glutamate. Glutamate, the inflammation markers too, like tumor necrosing factor, prostaglandin, interleukin, all are going to give us that sensation of pain. Now we also have our inhibitors decreasing the sensation of pain. We're going to have the GABA neuron, glycine. We're going to have serotonin, 5-HT. We're going to have norepinephrine. And we're also going to have morphine. Now remember, morphine has endogenous receptor in our body. So it's not the morphine that we give as a pain medicine, but our body is also able to secrete some pro-markers of morphine. So we have different receptors. We have the mu receptor, which act on the endorphin. We have the delta, which act on the enkephalin. And we have the kappa, which act on the dynorphins. So it's important as well to know these receptors, because later on we're going to see different medicine that act on different receptor, and different receptor are giving different side effect of the same drug morphine. So this is the, I can say, the ascending and interpretation pathway of the pain. Now we're gonna talk about the descending pathway. Remember, we saw that there is a descending pathway of the pain that acts as a modulator to make sure that we don't feel so much pain, because even the body don't want to feel pain. So let's erase this and talk about the descending pathway. So the descending pathway is going to begin on the periaqueductal gray matter. So the periaqueductal gray matter is located in the midbrain. And it's going to send some impulses to the pons on the locus ceruleus to secrete norepinephrine. So after the pain reaches the parietal lobe, the higher somatosensory cortex, these descending pathways are going to come into action on the periaqueductal gray matter located in the midbrain. It's going to send some impulses to the pons on the locus ceruleus. And it's also going to send some impulses to the medulla to secrete serotonin at the medulla site. And in the medulla is both epinephrine and norepinephrine are going to act to decrease the pain. So this is an overlooked picture of what the descending pathway is going to do. But actually the mechanism is quite a little bit complex than this, but I just want you to have a feel first. So on the periaqueductal gray matter, we have the midbrain. It's located in the midbrain. This is where the descending pathway starts. And we're going to go down to the locus ceruleus, producing in the pons, producing norepinephrine, going down to the medulla, producing serotonin. They're both going to inhibit the pain. In the medulla, this is going to be on the raphe nucleus. Yeah, they are all going to decrease the pain. Now let's see how all is going to work out all together. So here I'm going to draw a diagram here. So this part is going to be our spinal cord. This part is going to be our medulla. This part is going to be the pons. This part, midbrain. So in the midbrain, we're going to have our periaqueductal gray matter. In the pons, it's going to be our locus ceruleus. In the medulla, on the raphe nucleus. And the spinal cord on the dorsal horn. So how this descending pathway is gonna work? So I'm gonna color code it so we know the pain is gonna be in red and the inhibitor portion is gonna be in green. So let's see how all this works. We saw that when we first have pain on our muscle cell, we have pain. The pain is here. So we have our fiber, the A delta and the C fiber are going to conduct that pain. They're going to get into the dorsal horn where they're going to enter the gate control pain. On the gate control pain, we have the laminar 2 zone. We have the substance gelatinosa, which is going to tell if this sensation is going to be perceived as pain or not. So if this sensation, if this gate decide that the sensation is going to be perceived as pain, what is going to happen? We're going to have an excitatory neuron that is going to conduct that pain. So our excitatory neuron is going to take the pain and it's going to be our glutaminergic neuron. Our glutaminergic neuron here is going to transport the pain here. It's going to go up in the midbrain. When it gets in the midbrain, we saw that we have the periaqueductal gray matter, and this is where the descending pathway starts. So after we have the transduction, the transmission, the modulation, and we perceive it as a pain, the periaqueductal matter is going to start the descending pathway. So in the periaqueductal matter, this is our the glutaminergic neuron. It's going to release glutamate neurotransmitter, which conduct pain. And here we have our enkephalin. Remember, we saw enkephalin when we were talking about the morphine receptors, right? So our enkephalin is conducted by the delta receptor of opioid, right? So when this glutaminergic neuron releases enkephalin, normally enkephalin is here next to the GABA neuron. When it's not activated, GABA works. But once it's activated by the glutaminergic neuron, it inhibits the response to GABA. So this enkephalin is going to be activated and it's going to go and inhibit GABA. So because it inhibits GABA, the action potential here from the glutaminergic neuron is able to pass through because there is no more inhibition. It passes through and gets into the raphe nucleus inside the medulla. Now, when it gets inside the medulla, the raphe nucleus, what it's going to do is going to encounter another enkephalin. So here it's going to release our glutamate neurotransmitter, and this is our enkephalin here. Enkephalin. Now enkephalins are going to be activated again to inhibit GABA. Same thing happened. They are activated and they inhibit the GABA. Now once the GABA is inhibited, the nucleus, the raphe nucleus in the medulla, we say was secreted norepinephrine. So these inhibition are going to promote the release of serotonin. My bad. This inhibition here are going to promote the release of serotonin, neurotransmitter here. We have serotonin here, which is going to decrease the pain and activate other enkephalin here, stimulate the enkephalin release to decrease the pain. Now, this glutaminergic neuron is not just going to go into the midbrain, but it's also going to transmit some impulses here into the locus coeruleus. So we saw that the locus coeruleus is where the norepinephrine is secreted. So we have this neuron which is going to get that impulse. Because it's excitatory, it's going to decide to secrete norepinephrine through the alpha 2 stimulation into the pre and postsynaptic. So norepinephrine comes down here and decrease the pain. And this is how the descending pathway works. So we have a pain stimulus, go through the gate, decide to be a pain stimulus, transmitted by an excitatory neurotransmitter, glutamate goes into the brain, activate the encephalin to inhibit GABA so he can pass through the raffinucleus. Here he does the same thing, activate the encephalin to inhibit GABA. The raffinucleus senses that GABA is inhibited and it produces the serotonin. Serotonin inhibit the pain and make sure that other enkephalin here diminish the pain. Now this glutaminergic excitatory neuron is not going to stop there. It's also going to bring the impulses into the locus cerebrus. Sorry, I can't speak. Into the locus cerebrus. The locus cerebrus is going to secrete norepinephrine through the alpha 2 receptors, go down and block the pain. And this is how the body has his own system to help us feel less pain. And this is all I got for the neuroanatomy of the pain. I hope this video really helps you. If you have any comment, please drop down below. If you like the video, please subscribe, like, and share. And see you on my next videos. Bye.